Okay, so now we're going to pick up with respiratory, and we left off at asthma. So when we're looking at asthma, when clients are having an attack, they can have different levels of an attack. So it goes mild to severe, and in a mild attack, they just have some wheezing, their chest is going to feel tight, they'll have a little bit of a higher respiratory rate than usual, and they're going to be breathing out longer than they usually do, so they have a prolonged expiration time. As attacks get more severe, they're going to be using more and more of those accessory muscles to breathe. Those are the ones in the rib cage, like that you'll see moving between the ribs or in the neck. The wheezing will get louder, they'll get more and more fatigued, they may have difficulty talking to you because they can't pause the talk while breathing at the same time, and they'll have anxiety because they feel like they're not getting enough air. If they have a bronchospasm, alright, and it's severe enough that it clamps off all blood flow or all airflow to the chest, then we're not going to hear any air movement at all, and the patient will often become unconscious because they're not getting any oxygen in that part of the lung. It would be called a silent chest, and that's because if you use your stethoscope, we no longer hear wheezing, we no longer hear any type of air movement going on. This would be a severe complication and a sign that they have respiratory failure. If wheezing goes away, especially if we haven't done anything to treat it, then that means that the airway has completely occluded or been blocked off. This is also a very severe complication, and it requires immediate medical help. Status asthmaticus is a complication where they've tried their normal medications, but the bronchospasm isn't relieved. So the bronchospasm gets more severe, and it can lead to respiratory distress and arrest. Let's see here, sorry, my slides are getting out of order. Alright, so one of the tools that we use to help patients manage their asthma is a peak flow meter. So this is a device that has a little gauge on the top. You can see the numbers. You can also notice that it goes red, yellow, green, kind of like traffic lights. Right? What happens is patients who are monitoring their asthma should be blowing into this device and breathing into it. And it will make the gauge go up, and it will give them a number. They'll have their normal number. We like to see them above 400 or in the green area. But if their numbers are off or going down, it signals to them that their asthma is starting to become uncontrolled and they need to monitor it. They may need to adjust their medication schedule, or if it's in the red, they need to go get medical help. So green would be anything that's 80 to 100% of their personal best. So they have to know what their norm measure is. We want them in green because that means their asthma is under control. Yellow is where they're 50 to 79% of their personal best peak flow. So say their normal peak flow is 400. Yellow would be if they were like between 200 and 300 instead of up by their green area. Right. It's a signal that the asthma is getting worse, that they may need to use their quick relief medication or take other meds. They should notify their doctor. They should always carry their emergency asthma or rescue inhalers, they're called, medications with them, because it's more likely that they're going to have an attack. If they're in the red, that means they're less than half of their normal lung capacity. So they're below 50% of their personal best. This is a medical alert. They need to take their quick relief medicine right away, and they need to get to a doctor and seek some help so that they can get treatment before they go into more severe respiratory distress. This is just a chart that was created to show you kind of what it might look like if a patient was monitoring their peak flow. So the first 6 days, the patient was taking their peak flow, but they hadn't been treating their asthma. So notice how their peak flow can be very low, around 150, and then they'll have spikes up, right? they have a lot of highs and lows, and that's not really good. We want them to have more of a regular kind of line, so it's not up and down, up and down. That means they're having little asthma attacks or airway spasms that are going on. At day 7, they start treatment, which is right there in the middle. So towards the end of the graph, days 8 through 14, notice how their personal best or their trend goes up. All right, so overall, just their treatment is helping to increase their lung capacity and function. And then also notice how they have a lot less severe of the dips or the highs and lows. So to treat asthma, one of the things that we want to do is figure out what the person's triggers are and get rid of them if we can. So we could give them anti-allergy medications, like if it's pollen and hay fever, that's a trigger to them. This might mean that if it's a child who has a family pet and they do testing and find out he's allergic to their dog, they have to get rid of the dog, right? But one of the biggest things with asthma is that hyper-reactive sensitivity to their triggers. So if we can manage them, change their habits, give them medications, then we can limit the amount of triggers they're exposed to limit the amount of asthma attacks they have. They should also monitor their peak flow rate with that meter so that they can get an idea of how their lung function's doing, stay on top of it, treat preventively if they need to, and know when to get to a doctor. If they're having an acute episode, an asthma attack in other words, then they'll probably need drugs, and those drugs are geared at reducing the airway inflammation or the swelling that's going on and to stop the bronchospasms. So medications that will help with the inflammation would be steroids and bronchodilators, so they dilate or open up the bronchial airways. They can also help with bronchospasms because they're going to relax smooth muscle that goes around the bronchioles to help them to be able to open up. They can also treat them with beta-2 and agonist, and these are ones that also help with their bronchospasms as well. The next disease we're going to talk about is is emphysema. So emphysema is a chronic and progressive lung disease. What happens is that your lungs are usually elastic. They stretch and they recoil, and that's how you breathe. What happens in emphysema is that they lose that elasticity, and then air gets trapped in the distal spaces or the tiny air sacs of the lungs, and those eventually just keep getting enlarged. And they can get to the point where they get so enlarged that they pop or destroy the alveoli and they no longer work at all. The enlargement of the air sacs leads to the lungs getting hyperinflated because air gets in but it can't get out because you don't have that recoil or that squeeze to push air back out of the lungs. What happens is that more and more the lung gets hyperinflated, they get a very barrel chest appearance to them. And I have an image coming up to show you. But if you've seen people who have emphysema, you know that their chests look very large or a lot thicker than they should. What happens is that hyperinflation, an abnormal lung shape, causes an obstruction to the lung tissues. And then they also get a problem where that inflammation, that obstruction blocks off circulation to the lung as well to impair the ventilation perfusion match. So patients who have emphysema over time, they're going to have an increase in breathlessness, and they're going to have difficulty breathing with exertion, which means they can't do physical activity well, exercises out, and as it progresses, they're even going to have difficulty like walking to the bathroom without getting short of breath. This is due to that ventilation perfusion mismatch and the hypoxemia that goes on with the disease. They'll have very quiet, distant sounding lung sounds if you listen with a stethoscope. They will often lead to malnourishment problems because they're using a lot of extra effort to breathe to try and get the air that's trapped in their lungs out, and then that increases the amount of calories they're using just to breathe, and then they don't have calories left to go to their body and they end up malnourished. They'll have the barrel chest, They are often breathe through pursed lips, which means they have their lips shaped almost like they're puckering up, and they're trying to breathe through there. And the nickname for them is the pink puffer disease, because when it first starts, they're still not hypoxic or cyanotic. That builds up as they go on. So they breathe quicker, but they're still pink. They're not blue from low oxygen until the disease gets further in. So it's primarily a disease of smokers. There's also a recessive inherited disorder that's pretty rare. You see it most often in Scandinavian, Jewish, African American, and Japanese people. And what happens is they're missing an enzyme that protects their lungs from injury, so they get damaged. Either one of them we don't have a cure for, so we try to prevent it by keeping people from smoking, and we can support them, but we can't get rid of it. These are the kind of airway changes that go on with somebody who has emphysema. So normal is down here, nice pink, tiny air sacs like they should be, healthy sized membranes or walls around them. Up here, these are the hyperinflated ones. Alright, so they have way too much air in them that can't get out because there's no elastic to these walls anymore, so it can't recoil and push the air out of them, so air stays trapped. And they get bigger and bigger and bigger, more stretched, until eventually they pop. And then we end up with these huge holes in the lungs of just inflated air that won't go away. Alright, so that's what's referred to as the alveolar destruction. The big bubbles that they get are either a bullae or a bleb. So a bullae is in the large spaces within the lung tissue or the lung parenchyma, and a bleb is in the ones that are along the edge adjacent to the pleural cavity. This is the barrel chest that they have. Notice how it's much thicker or wider front to back than a normal person. To treat emphysema, we want to keep them from having complications of it as much as we can. We want them to stop smoking so we can limit the progression of it. They will get medicines called expectorants. These are things that help them to cough junk up to try and help them clear mucus out of those trapped airways. They can also get bronchodilators and steroids to try and open up their bronchi to make the diameter larger and easier for air to escape through. They can get low-dose oxygen therapy as their saturations start to go down. If they get respiratory infections, they'll have to be treated with antibiotics. And then we want to prophylactically try and make sure they get their flu and pneumonia shots so they don't get infections on top of their normal damaged lungs. That would make it even harder to breathe. Alright, so I'm going to stop here at this one. The next video will pick up with chronic bronchitis.